So I'm going to discuss a topic, mass lesions of the liver, because I'm sure there's nothing that provokes more anxiety in doctors than those who order a scan or an imaging test for something nonspecific, diarrhea, abdominal pain, and then the report comes back, there's a mass lesion in the liver, and then people start having seizures. So it's not really that difficult. And I'm going to take you through, I think, an algorithm, and hopefully this will help you tackle these problems in a kind of a systematic fashion. So when you see a mass lesion in the liver, I would say 95% of the time, it's going to be one of these. It's going to be an abscess or some sort of tumor, either malignant or benign. And the other 5% will be the zebras, which ultimately you may have to resort to some biopsy or something. But in actuality, 95% of the time, it'll be one of these lesions. And as I discuss, the workup is actually very straightforward and radiologic based now. So the first distinction you have to make when you see a mass lesion in the liver is this an abscess or a tumor? And that distinction is actually fairly easy, because what is an abscess? An abscess is basically a pocket of infected material, inflammation, and so it's essentially a large infectious nidus in the liver. So it's not unexpected that the symptoms of an abscess reflect those of a patient who has a systemic infection. So fever, pain is rare, but if it is present, it is typically not severe. And abscesses usually cause a little bit of pleuritic discomfort, especially if they're superior and impinging a little bit on the diaphragm. Patients will have other nonspecific symptoms and signs like constitutional symptoms, and occasionally they'll also have symptoms of lower GI tract pathology like diarrhea, because if you think about it, abscesses are actually metastatic infection from some focus, usually down low in the GI tract. The signs on physical, typically temperature, right upper quadrant tenderness, jaundice, usually not so much a reflection of the abscess, but just the fact that the patient is infected. And often with an abscess, especially if you have an amoebic abscess, you'll have dullness at the right. And this is something called a sympathetic effusion that these abscesses will tend to cause in the right lower lung. And it's called sympathy because it's in close contact to and sympathetic to the lung. Ascites is rare. And it's an infection, so you would expect to find leukocytosis, probably an anemia of chronic disease, some mild jaundice, alkaline phosphatase elevations because it's infiltrating the liver. But a lot of these findings are just basically nonspecific for an infectious process. But if you have a hepatic abscess, the main issue with a hepatic abscess is to determine whether you're dealing with an amoebic abscess or a pyogenic abscess. And the demographics of the two abscesses are very distinct. Amoebic abscesses tend to happen in younger folk. Pyogenic abscesses tend to occur in older patients. And there was a large study that was done at LAC-USC County Hospital that showed that the vast majority of patients who came with amoebic abscesses tend to have Hispanic surnames, tend to come from countries that have underdeveloped systems of water sanitation. Pyogenic abscesses usually are a result of some underlying lower GI tract pathology, whether it's diverticular disease, diverticulosis, appendicitis. So as you would expect, you see those in older patients with chronic liver conditions. Amoebic abscesses tend to be more symptomatic than pyogenic abscesses, which are kind of more indolent. And of course, the causes are different. So amoebic abscess is caused by Entamoeba histolytica, pyogenic abscesses are bacterial. So the diagnosis of an amoebic abscess versus a pyogenic abscess, you can look at serologies, but the main issue is aspiration. And you aspirate the abscess, and my old mentor at LA County Hospital used to say you should aspirate the abscess, look at the abscess, look at the aspirate, smell the aspirate. If it has no odor, it's likely amoebic. If it's very malodorous, it's probably pyogenic, especially if it's anaerobic. So this is an abscess that was aspirated, and it shows that typical kind of tomato-colored, anchovy paste-looking, non-odorous aspirate. And of course, this patient had an amoebic abscess. The treatment of an amoebic abscess is chloroquine or Flagyl. And actually, chloroquine is very specific. It only treats amoebic abscesses. So they used to use chloroquine as a diagnostic therapeutic intervention. If you have an abscess, you can put the patient on chloroquine. If they improve, it was likely an amoebic abscess. If they don't improve, then you're probably dealing with a pyogenic abscess. Drainage has always been controversial. In an amoebic abscess, drainage is really not necessary. And do you put drains in pyogenic abscesses? There's been a lot of studies looking at that, and it's controversial, but the fact is that antibiotics penetrate abscesses very well. And in another large study that was done at LA County Hospital, patients who were treated with and without a catheter, there was actually no significant difference. So catheter drainage is not necessary. So if you've decided you don't have an abscess because the patient is just not acting like an infected patient, then you're likely dealing with a tumor. And then the next issue you have to decide is, well, is this a malignant tumor? And in most cases, we're talking about HCC, liver cancer, or is it one of the benign tumors of a hemangioma, a focal nodular hyperplasia, or an adenoma? Well, the distinction there is also fairly straightforward. When you think about HCC or hepatocellular carcinoma, it's all dependent on the demographics of the patient. Is the patient from a country of high endemicity, like in Asia? Does the patient have underlying cirrhosis? Does the patient have underlying chronic hepatitis B? So underlying chronic liver conditions are usually the prerequisite for HCC. So obviously, if you have a patient with a mass lesion, a tumor, and they have hepatitis B, if they have cirrhosis, you should start thinking that more likely than not, this is an HCC. Hepatitis B has the strongest association with HCC. So it's incumbent upon us to screen all of our patients for hepatitis B if you discover a new mass lesion. The longer they've had the hepatitis B, the more likely they are to have a liver cancer. So young patients who get the hepatitis B young in age, like the Asians, there'll be a very high chance that the mass lesion you see is an HCC. The most important thing about hepatitis B that we should realize is that you can get liver cancer with hepatitis B in the absence of cirrhosis. And that's one of the few conditions where that exists. In other cases, whether it's alcohol, NASH, hepatitis C, you need underlying cirrhosis. Have they had exposure to chemical carcinogens? That's something that we should look for in the history to indicate whether you're dealing with an HCC. But of course, again, underlying cirrhosis, if a patient has a mass lesion and underlying cirrhosis, then HCC should be at the top of your differential until proven otherwise. Clinical presentation, it can be symptomatic or it cannot be symptomatic. HCC can start, and obviously when it starts early, in early stage HCC, the patient may not have any symptoms or signs at all. But when the HCC is more advanced, then the patient may show constitutional symptoms of having a malignancy. Obviously, if they have a large hepatic mass that you can palpate, and if you can even put your stethoscope down on the mass and get a hepatic bruit, then that's very pathognomonic of an HCC. Laboratory tests are not necessarily that helpful, and we're falling more and more away from AFP, which is not very accurate. But I was just here with an NIH meeting yesterday where we're going through new biomarkers for liver cancer and other malignancies. I think in the future, maybe within the next 5 years, we're going to be relying a lot more on liquid biopsy with very specific and sensitive biomarkers. So alpha-fetoprotein so far is all that we have, but again, it's not that good. Again, the diagnosis of HCC really depends on the imaging. And there's a lot of different modalities that we look at. But in general, HCC has a very characteristic imaging feature. And this imaging feature is diagnostic. So in the old days, tissue used to be tissue was the issue, but now tissue is really not the issue anymore. The clinical picture will kind of focus you towards HCC, but the diagnosis really relies now on imaging. And you can see here, the imaging shows in this multiphasic CT scan, you see in the arterial phase, you see hyper-intense lesion that on the venous phase, the contrast washes off. So that's the key to HCC, arterial enhancement in venous washout. And if you're lucky, you also will see a small capsule around the tumor. I don't have a pointer, but the tumor is that small tumor sitting near the spinal cord there. So the key to diagnosing HCC is to order a contrasted scan. If you order a non-con CT or a non-contrasted MRI, then you are not going to be able to diagnose HCC. So always, if you're thinking HCC, order a contrasted scan, because you need to see the arterial enhancement followed by the slow venous washout. And I sometimes like to tell my fellows, think of wax on, wax off. So that's your HCC, contrast on, contrast out. You should try to get your radiologist to report your nodules using the new LIRADS classification. And this is very important. It helps us determine whether the nodule that you're dealing with is potentially an HCC or not. And you can see the LIRADS classification relies on arterial phase enhancement, tumor size, but then again, the enhancement, the washout, the capsule, and whether there's any threshold growth in the lesion over serial imaging. And then the radiologist will classify it as LIRADS 3, LIRADS 4, or LIRADS 5. LIRADS 3 is unlikely to be HCC with a 37% chance. LIRADS 5 is almost definitely an HCC with at least a 95% chance. LIRADS 4, we're determining is very likely going to become an HCC. So if your radiologists aren't already reporting your CT and MRI scans using these LIRAD classification, they really should, because this is the standard now that is being recommended by all the societal guidelines. Treatments for HCC are becoming more and more sophisticated. In the old days, you either resected them, you transplanted the patients, but now there's a lot of local ablative therapies that we can use. And so the recommendation is in a newly diagnosed HCC, please try to send the patient to a tertiary center to be evaluated by probably a multidisciplinary group. Transplants, if the tumor is within what they call Milan criteria, so 1 lesion less than 5, multiple lesions up to 3 with the largest less than 3, no evidence of vascular spread or metastases, then that's good. Finally, if you're not dealing with an HCC, you're probably dealing with one of the benign lesions, a hemangioma, an FNH, or an adenoma. A hemangioma is a vascular tumor, blood-filled, surrounded by fibrous septa. Is the most benign tumor, more common in women. Less than 4 centimeters is a small hemangioma, usually called an incidentaloma, because we always find them incidentally when we're imaging for other reasons. A giant hemangioma is usually less than 4 centimeters. And again, hemangiomas are diagnosed dependent upon the imaging. The take-home message here is that with hepatic mass lesions, we're falling away from doing guided biopsies anymore. Everything depends on the imaging. But for me, the best imaging for hemangioma, I think, is to order an MRI scan. Because if you see that so-called light bulb sign on T2 weighted images, that's very, very specific. So I like MRIs for hemangiomas. But if you look at a hemangioma, the characteristics are much different from wax on, wax off of an HCC. A hemangioma, on the early arterial scans, there will be no lighting up of the lesion, but in the delayed venous phase, you'll see a slow peripheral enhancement of dye coming in centrally on the tumor. So this is a CT, this is an MR. You can see the early arterial phase, nothing in the tumor. Late venous, there's a peripheral seeping in of the contrast, and that's a hemangioma. But if you get the big light bulb sign, the big bright lesion on T2 weighted images on an MRI, then that's pretty diagnostic. So for me, if you're thinking hemangioma, order your MRI. Hemangiomas, for the most part, if they're asymptomatic, not much needs to be done, but of course you sometimes have those large hemangiomas, especially if they're peripheral in the liver. There's always a risk of potentially bleeding. So in those cases, you may want to send the patient for consideration of surgery. Finally, adenoma versus FNH. This is the big distinction that needs to be made. But in general, adenomas are driven by oral contraceptive pills. FNHs, not so much so. So it's not unusual that adenomas were not really that prevalent until the use of oral contraceptive pills. The presentations are very similar. The big distinction in natural history is that an adenoma has the potential to rupture and bleed. So that is something to be aware of. FNHs, for the most part, there's no risk of rupture or bleed. So that's one important distinction. Liver tests, serologies are not helpful. And again, diagnosis by biopsy is also not very helpful. You depend on the imaging again, and there's a lot of different imaging modalities. And again, when it comes to adenoma versus FNH, I like to go with the MRI again, because on the MRI with an FNH, if you can see that very characteristic avascular central stellate scar, then that's diagnostic of an FNH. So here's an FNH on an MRI. You can see the avascular central stellate scar. And when the radiologist sees that, then with a lot of confidence, they could call it an FNH, and then you can relax. Hepatocellular adenomas, that is not a central stellate scar because you see contrast in there. So that either means that that's some central necrosis or possibly a rupture or possibly even a transforming HCC. So what I like to do is I like to order a liver spleen scan, because a liver spleen scan is taken up by Kupffer cells, and adenomas don't have Kupffer cells. So if you do an imaging like a CT or an MR and you have a lesion and you're still trying to decide FNH versus adenoma, you can order a liver spleen scan, and the adenoma will not show up. It'll show up as a big absent spot. So last slide, treatment. Adenomas, of course, you stop the oral contraceptive pills. Often the adenomas will start to regress. You should actually consider sending patients with large adenomas for possible surgical resection because of the risk of bleed, rupture, and transformation to HCC. FNHs are, for the most part, once you diagnose an FNH, you can really relax because you usually don't have to intervene with an FNH unless, for example, it's very large, very peripheral. There's some symptomatology related to the mass effect of the FNH. But for the most part, once you make a diagnosis of FNH, the patient is probably going to do fairly well. And with that, I will say thank you.